right, well, welcome everybody. Thank you for joining us today to talk about updates on Leqembi for early stage Alzheimer's disease. My name is Kelly Bender and I support outreach for UW Medicine Neurosciences. I'll be facilitating today's webinar in partnership with Genevieve Wanucha, communication specialist for UW's Neurology's Memory Hub, Memory and Brain Wellness Center, and Alzheimer's Disease Research Center, or ADRC. We're going to use the Q&A feature today to ask questions during the webinar, and at the end of the presentations, we'll go through some of your questions for today. We have a panel of experts in which I'll take a few moments to introduce. Darla Chapman is a nurse practitioner for the UW Memory and Brain Wellness Center. Darla specializes in care for older adults with mild cognitive impairment and dementia. She has experience in diagnosing and treating many types of neurodegenerative diseases, including Alzheimer's disease, frontotemporal dementia, dementia with Lewy bodies, Parkinson's disease dementia. She enjoys approaches to care that focus not only individuals living with memory loss, but also health and needs of their care partners. She is actively involved in the Alzheimer's Disease Research Center as a principal investigator and clinician for several clinical trials investigating new medications and treatments for Alzheimer's disease and other types of dementia. She teaches nurse practitioner students and lectures for the University of Washington Nursing School. Dr. Tom Grabowski is a UW professor of radiology and joint professor of neurology. He's a neurologist and an expert on the diagnosis and treatment on conditions affecting memory, language, and cognition. He's the director of the UW Memory and Brain Wellness Center. He is also a cognitive neuroscientist who directs the UW Integrated Brain Imaging Center, dedicated to investigating the organization of the brain and the basis of cognition using MRI approaches. Dr. Michael Rosenbloom is a board-certified neurologist at the UW Medicine Memory and Brain Wellness Center, where he directs the clinical trials running the UW Alzheimer's Disease Research Center, or ADRC. He previously served for 13 years as the director of Health Partners Center for Memory and Aging in St. Paul, Minnesota, where he led clinical research and cognitive screening for dementia, intranasal therapeutics, and non-invasive neurostimulation for neurodegenerative diseases. As a reminder, we'll be recording today's presentation and share it out with all the participants, as well as those who weren't able to make it today. Today's presentation will include Dr. Grabowski providing an overview, Dr. Rosenbloom talking about mechanisms and dosing, while Darla talks about safety, side effects, and monitoring. And with that, I will go ahead and turn things over to Dr. Grabowski.
Great. Well, good afternoon and greetings from UW Medicine. Kelly, can my screen be visible there? Looks good?
Looks great.
Great. So I'm the director of the UW Medicine Memory and Brain Wellness Center, and we're all here today because of our interest in these recently available treatments for early mild Alzheimer's disease that go by the general name of amyloid-clearing infusion therapy. We're going to talk a lot about Lecanemab, as Kelly has said. We'll also be updating the webinar that we gave last year, and over that period of time, we have gained a lot of experience that will inform this presentation, and we also have a newly available second agent that we'll talk a little bit about. And I'm going backwards. So I'm speaking on behalf of our whole provider team shown here. This is Dr. Rosenbloom. This is Dr. Chapman, so you'll hear from them in a few minutes. We envision a world in which people with memory loss live well within a community of support, and we're all looking forward to the day when threats to memory and brain health are anticipated and prevented as the standard of care. And as you'll hear, these treatments that we're talking about are a step in that direction. So I mentioned that we're going to talk mainly about Leqembi, which is the brand name for lecanemab, shown on the left there. Kisunla or donanemab on the right is recently FDA approved and is something we anticipate will be available in the very near term. So we'll talk a little bit about it. It's the same class, same basic kind of agent. And we'll be posting this webinar video on our website. You see the current web page here, but we will keep this updated, the text and probably future informational webinars as well. The purpose is to give you something to to prepare you for discussing these treatments in our clinic, to give you a persistent resource you can go back to and refresh your memory, and try to make sure that we all get to the best decision for each of our patients. So the first basic thing to understand if you want to understand these treatments is that there's two kinds of diagnosis that we make in your visits to our clinic. And the first is what I'll call a cognitive diagnosis, or what's wrong with memory and thinking. And this is going to go on the spectrum from typical normal cognitive aging through subjective complaints. And it is, by the way, normal to be worried about your memory as you age. It's our job to help sort out whether that really signifies something else going on. Mild cognitive impairment, which is a state where you have measurable memory trouble or cognitive trouble, but you're independent. We don't use the term dementia for people who have these early stages, and that can persist a few years. And then once there is some significant degree of dependency on other people for some of the things of life, like keeping track of medication, keeping track of appointments, keeping track of the money, those kinds of things, we start to use the term dementia, which starts out mild and can get worse over time. That's cognitive diagnosis. The second level of, and this circle is to remind myself that we're talking today about treatment which is appropriately started at the stage of mild cognitive impairment or very mild dementia, people who are essentially their own decision makers. The second level of diagnosis is the causal diagnosis, like what's the matter with the brain to explain what's the matter with memory. What would we see if we could look under the microscope? And for Alzheimer's disease, we see these buildups of amyloid protein, and they occur as plaques, like all these brown circles on this microscopic section of the brain are plaques of abnormal protein in the brain. And we can't show you, what the brain looks like before and after treatment with these agents, but the closest thing we have to that is a PET scan, an amyloid PET scan, shown here before and after treatment with one of these amyloid-clearing agents. And the upshot is that it is possible over time to remove the bulk of this amyloid burden from the brain. And we think of amyloid as one of the insults that is causing Alzheimer's disease. These agents, lecanemab and donanemab, are what we call monoclonal antibodies. They're immune system molecules that have been manufactured that will be specific to amyloid protein. They will, they're injected as an infusion into the vein through an IV. They seek out and find amyloid protein, and once they kind of glom onto the amyloid protein, your immune system can take that complex of drug and amyloid protein and literally remove it. And this is quite effective. Over a period of 18 months, the difference between the untreated group and the treated group is really dramatic. You can see this orange line's plunging really to the bottom of the curve, and you get, if you have an amyloid PET scan done at that point, it will typically be negative. So this really does a dramatic job of clearing amyloid protein. And it also, and this is the important thing from the FDA's point of view, it also improves cognition. So and the easiest way to explain this is if you look at the sort of curves over time, so this is declining cognition as expected over time in early stage Alzheimer's disease. These curves are diverging. If you think about how much an untreated person would decline at the 12-month mark, it takes the Leqembi group an additional 5 months to get to that same level of impairment. So you can think of this as saving you 5 months of good function over that 18 months. In the field, this has been described as a modest benefit. It's clearly a benefit, but you need to understand that it's not a cure. It's not stopping or reversing Alzheimer's disease. It's slowing it down. And the other thing to say, it's really not appropriate for everybody. We'll talk about that a little more here in a second. Taking it as a commitment, these infusions need to be done repeatedly, every 2 weeks in the case of lecanemab, every month in the case of donanemab. And it requires periodic MRI scans to be sure it's being done safely. And I want to talk a little bit about that safety aspect next. We have to monitor for a side effect that we call ARIA. It stands for amyloid-related imaging abnormalities. It's a mouthful, so ARIA for short. And the reason that imaging is in there is because these side effects are typically picked up on brain imaging. They're typically not symptomatic. And that is, people don't know that these are happening. We have to find them on an MRI scan most of the time. And the way I like to explain this is the amyloid protein that's building up in the brain is also building up in the walls of some of the small blood vessels in the brain. And the amyloid protein is going to, or the amyloid clearing agent is going to find it in the vessel as well as in the brain substance. It's going to pull it out of there. And sometimes the vessels get leaky. We don't know if there's some inflammation or what, but fluid can seep into the substance of the brain. That's kind of shown here on the left. This is an MRI scan kind of with a kind of section through the patient's head. And this side looks pretty normal. And this side, you can see the white signal, and that's the sort of fluid buildup in the brain substance, and the MRI can sort of detect that. It can also be the case that a sort of microscopic level of bleeding can happen. We call this microhemorrhage, and these little black dots that you see on this corresponding image here are what we see on the MRI scan if that happens. So ARIA-E for edema, ARIA-H for hemosiderin, the sort of blood breakdown product that can show up on the MRI scan. And this ARIA side effect can happen anytime during treatment, but especially in the early months of treatment. And if we see changes on the MRI scan, we can interrupt treatment, let the brain settle down before we resume. And most patients are able to resume and finish treatment. But there is this safety consideration. And you'll hear more about that from Dr. Rosenbloom and from Darla. So prescription of these agents is a case-by-case decision. We've talked a little bit about medical factors that kind of bear on whether this is appropriate for a given patient. The cognitive stage, what the brain scan and the biomarkers show, and your individual health factors, including what medicines you might be on. For example, we wouldn't want to give this to someone on a blood thinner. But there also are personal factors that you bring to the conversation, how you weigh this degree of benefit against the risk and cost of the treatment, cost both in terms of money and also in terms of sort of commitment and lifestyle, how well Medicare or other insurance that you may have covers this for you. The good news is Medicare covers, but insurance is a complicated business, and we run into issues with Medicare Advantage plans or other carriers. So these are things we help you sort out. And then, how easy or hard it is for you to get to the infusion center on a regular basis. So we'll determine all this over 2 or 3 visits to the memory and brain. And the discussion and decision is really a joint one between you and your memory and brain provider. So this webinar can't really say if this is appropriate for you specifically, but we can at least explain to you what the issues are. And then finally, the amyloid clearing treatment that we're talking about is only part of your treatment here. You're sort of added to the standard of care that we currently have, where we frequently prescribe medicines that can enhance cognitive function, help the brain cells that are surviving function better, make a difference in daily life. Some of those medicines are listed here. It's also really important that we consider all the other medical factors that can gang up with Alzheimer's disease to cause decline. So there's a lot of emphasis on vascular and heart health, sleep health, mental health. And then there are non-medical measures that are important for brain health. And we've done a lot of innovative work at the Memory Brain Wellness Center along these lines, but you need to learn about strengths that you have in spite of memory decline and how to make the most of them, how to build healthy habits to promote your functional independence. And a lot of this we sort of develop in our interaction with our community center we call the Memory Hub here on the Fry Art Museum campus near Harborview. So we have this one-time sort of orientation class we call Memory Loss: A Guide to Next Steps, which introduces a memory handbook that we've developed in our clinic. We have a 2-week intensive boot camp or mind and body wellness program for people with mild impairment and their family members. A variety of other programs that are centered at the Memory Hub. So if you haven't heard about these in your visits to Memory and Brain, you should ask your provider whether some of these things are appropriate for you. And just to close and say, we're excited about this. This is the first disease-modifying treatment that's been available for Alzheimer's disease. We've got a lot of good experience now bringing this to our patients in a safe way. The availability of lecanemab and donanemab really increased the value of early diagnosis and are leading, to the availability of new diagnostic tests that are able to make a diagnosis of underlying Alzheimer's disease with clarity really early on. And we expect more developments in the future and encourage you to follow along with us. So with that sort of overview, I'm going to introduce my colleague, Dr. Rosenbloom, who will tell you a little more detail about these amyloid clearing treatments. Thank you.
Well, thanks, Tom, for the introduction. And so I'll be focusing on the mechanisms of lecanemab and providing dosing information. Next slide, please. So you have heard from Dr. Grabowski about how the amyloid plaques and the nerve fibrillary tangles are critical to this disease process. And over 100 years ago, when this disease was first described, what was found were these circular plaques, known as amyloid plaques, located outside of cells. And then also in the lower right-hand corner, these nerve fibrillary tangles that were clusters of protein within cells. And these are part of a cascade that leads to progressive neuronal loss and the underlying diagnosis of Alzheimer's disease. Next slide. And so many of the treatments that are available right now that are disease modifying are designed to bind to the different species of amyloid, which forms those plaques. And the goal is to interrupt what is known as the amyloid cascade, which ultimately leads to loss of brain cells. So we're very excited in our field that we have a new class of drugs to treat Alzheimer's disease with. So the first one of these was known as aducanumab. And you heard today about Leqembi or lecanemab. And then earlier this year, donanemab, a third agent, was approved by the FDA. And so all of these are antibodies that bind to the amyloid species and remove them from the brain. Next slide, please. So this is a cartoon that shows exactly what is happening when someone comes to the infusion center. They receive this treatment through the vein, and then the treatment goes to the bloodstream and eventually crosses the blood-brain barrier. And you will see the drug as these Y-shaped entities. It's an antibody, and it's binding to these abnormal clusters of protein, the amyloid plaque, shown in the blue here. Now, once there's binding to the plaque, this is removed, and then an immune response is triggered where a lot of the immune systems or cells are coming to break down the protein and remove it from the brain. And that's essentially the mechanism of action of these drugs, is that they're triggering the removal and inflammation that leads to less amyloid in the brain. Next slide, please. Dr. Grabowski has also mentioned earlier on that these drugs are most effective in the earlier stages of Alzheimer's disease. We understand this condition is existing on a continuum that ranges from pre-symptomatic stages to eventually mild, moderate, and severe dementia. And so the population that benefits the most are those patients who have objective evidence of cognitive impairment, but intact everyday function, and that's known as MCI due to Alzheimer's disease, if they have evidence for Alzheimer's in the brain, and then also when they start to have mild deficits in their instrumental activities of daily living, mild Alzheimer's dementia. And so these are the two subtypes that benefit the most from this type of treatment. Next slide, please. We are really fortunate in that we have certain tools to help us confirm whether or not there's Alzheimer's pathology in the brain in living patients. And so this is an example of an amyloid PET scan, which involves given a ligand or an agent that binds specifically to amyloid plaques if they're present in the brain. And you can see on the right, in an Alzheimer's patient, you have more red-orange, which indicates binding to the plaques in the brain as compared to the normal patient who does not have such binding in the brain. Next slide, please. This figure is what was presented by Dr. Grabowski, and I think the punchline is that this drug, Leqembi, results in modest slowing of the disease process over an 18-month period compared to patients who are not treated. So the slowing is about 27%, which buys 4 to 5 months of delay over an 18-month period. There is a commitment of infusions every 2 weeks for the 18-month period. And you should know that this is not restoring lost function. So if a patient cannot drive after their diagnosis, it's unlikely that being treated with this drug will restore that ability to drive. Next slide, please. And this drug is not all rainbows and unicorns. There are certain significant side effects. The most common side effect had to do with infusion reactions, which is affected about a quarter of patients and involved a kind of an immune response, which is typically seen when patients are given infusions. That this could manifest itself as having chills or muscle aches or changes in blood pressure. And usually this is very treatable by nursing staff at infusion centers. As Dr. Grabowski mentioned, there are some central nervous system manifestations that take the form of either brain swelling, as you see in this picture on the left, or microhemorrhages in this picture on the right. And listed here is the percentage or the incidence of these findings in the patients who were studied in the clinical trial. Darla Chapman will be talking more about these side effects. The other thing to know is that the ApoE4 genotype, where you can have up to 2 copies, is a risk factor for having either ARIA-E or ARIA-H. the good news is that if you are on the drug treatment for 4 months and you haven't had any of these findings, it's likely that you're out of the woods and you're not going to manifest these side effects with the lecanemab treatment. Next slide, please. Now, there is some housekeeping that needs to be done prior to starting these infusions. Number one, we need to make sure that there's indeed Alzheimer's present in the brain. So one way to check for that are those amyloid PET scans that I showed you earlier. We have been traditionally doing spinal fluid analysis where patients will lie down on their side as pictured in the cartoon on the right, and the sample of spinal fluid is removed. And then we look for protein levels that will address the amount of amyloid in the brain and also indirectly tell you the amount of tau tangles in the brain as well. You may have heard about some research being done with blood biomarkers, which, as you can imagine, is non-invasive and very easy to obtain. And this is something that deserves more exploration and may facilitate our ability to confirm the presence of Alzheimer's in the brain. The other evaluations have to do with the safety of a patient. So in the clinical trials, there were some patients who had large bleeds in the brain, and so we want to make sure patients do not have a bleeding disorder. So we can check coagulation factors to make sure that this is working well in the patient. We also want to make sure the individual is not on a blood thinner like warfarin or Eliquis, which is contraindicated when we give drugs like lecanemab. I mentioned in the earlier slide that the number of APOE4 alleles that a patient carries can increase the risk for some of the amyloid-related imaging abnormalities. So we are doing APOE genotyping as well. And I'll show this in a later slide, but all patients need to have a baseline MRI to make sure that there's no excessive strokes or microhemorrhages in the brain at baseline. Next slide. This is a chart that documents the journey of all patients who come to the Memory and Brain Wellness Center. So many of our patients come to us as soon as they complain about memory loss. And so at our first visit, you'll see we're doing a history and taking labs. We'll do cognitive screening. We'll order a baseline brain MRI, and then we'll choose a certain type of biomarker, whether it be the amyloid PET imaging or spinal fluid. And then if we find positivity, then we'll talk about whether or not we should give the drug. We'll talk about the benefits. We'll talk about the risks. And then it will be shared decision-making between the patient, the family, and our staff to proceed or not with further workup. And so that has to do with the safety labs that I mentioned in the earlier slide, making sure that patients are not carriers of APOE4 or having multiple copies of APOE4, and looking at coagulation factors. And if we feel that the risk-benefit ratio is favorable, then we schedule patients for infusions and also surveillance imaging. Next slide, please. So if one of you were to become a patient of ours at Harborview, there are certain expectations to keep in mind. So at this point in time, all the infusions are being done at Harborview Medical Center. We have nurses who are wonderful, who partner with us and evaluate our patients as soon as they come into the infusion center. They will ask questions about your health, and many of these questions relate to some of the side effects that may be seen with lecanemab treatment. This includes headache, nausea, imbalance, confusion. This drug is given as an IV infusion at 10 milligrams per kilogram over an hour, and it's given every 2 weeks, rather frequently. And at the beginning, because about a quarter of patients treated with this drug have infusion-related reactions, we will observe patients for 3 hours. And once we follow a patient long enough, then eventually these observation periods will shrink to about 30 minutes. And so it will become about an hour and a half commitment. Next slide, please. As I mentioned earlier, we will be performing surveillance imaging to track any changes or look for any amyloid-related imaging abnormalities that occur with the 18 months of treatment with lecanemab. The majority of patients who have the amyloid-related imaging abnormalities have no symptoms. So one guardrail is to perform these MRIs relatively frequently. So in addition to the baseline MRI, we are having MRIs performed before the 5th, 7th, 14th, and 26th infusion, which amounts to a total of 4 surveillance MRIs. Next slide, please. Now, I've had about roughly a year of experience with treating patients with lecanemab, and there's certain questions that come up very frequently. Many of my patients ask whether they should take lecanemab earlier or can they wait 6 months to take this drug. And we now have some data that looks at patients who have less pathology in the brain, as shown by what's known as a tau PET versus more pathology in the brain. And so in some of this analysis, patients who have less pathology in the brain, meaning that they were treated earlier most of the time, these patients have better outcomes based on the data, where those dots that are farther to the left that favors Leqembi, you can see in those patients who had more pathology related to Alzheimer's disease, that outcome was still favorable, but not as positive as in the low brain pathology or the earlier stage group. So at least from this preliminary data, it supports treating patients sooner rather than later with this drug. Next slide. Another question I frequently hear from patients is, okay, so this clinical trial was for 18 months and you have a protocol for 18 months. What happens after I reach 18 months? And I think the answer is somewhat complicated, but we do have some data that is providing some suggestion of how to proceed. So this is a busy slide that includes information from the 18-month clinical trial, as well as what's known as open label extension, which is another 18 months for a total of 36 months. And so patients who were in the original clinical trial who received the treatment, which is shown in green here, they were continued for an extra 18 months for a total of 36 months of treatment. You have another group, which is shown originally in this black line, which received placebo for the first 18 months, and then were switched to the lecanemab treatment for the final 18 months of the open label extension. And you can see this is another green line in this final section here. Finally, there were patients who were on placebo, and then they were followed out based on historical controls. So these are patients who never received any treatment whatsoever, and we have historical controls of patients of what happens to them normally in terms of their cognitive function over time if they receive no disease-modifying drugs, and that's shown in this pink line here. And the punchline is that, you know, the patients who receive the lecanemab for the entire 36 months, their decline in cognition and function was slowed the most, followed by those patients who first received placebo and then were switched to treatment, followed by the historical controls, or those individuals who never received treatment whatsoever. And so that gap between the treated and the untreated group gets larger and larger as you go farther out to 36 months. So this is a suggestion that maybe there is some value in keeping patients on these drugs longer than 18 months, but more information is needed to know for certain. Next slide. So earlier this summer, there was the exciting announcement about the approval of donanemab. Next slide. The trial methodology was similar in some regards to the lecanemab trial, in that we had a little bit under 2,000 patients treated and receiving either the drug or placebo. Some of the differences had to do with stratifying patients based on the amount of tau in the brain, which tells us how much pathology in the brain. And so they gave results in terms of low amounts of tau versus the combined population. And the outcome had to do with a combined measure of cognition and function. And ultimately, what they found was that there was pretty statistically significant slowing in both the low, medium tau groups, as well as the combined groups, in terms of how they slowed on this combined measure of cognition and function relative to placebo. So it was a positive study. Next slide. Now, the first thought that comes up is, well, how does this compare to lecanemab, which is already available? And donanemab is also known as Kisunla. That's the trade name. And there are certain major points to highlight. So number one is that donanemab is more convenient in its dosing than lecanemab. It's given every 4 weeks versus 2 weeks. The other thing is that in the study, there is a precedent for using repeat amyloid PET scans to look at whether or not amyloid plaques were removed from the brain. And if they were removed, then in the trial, patients were stopped. And sometimes this occurred as early as 6 months, in which the drug was halted. And so, this is not an 18-month regimen, but could be as little as 6 months, sometimes more. But that is also evidence that this drug may be more convenient in its dosing than lecanemab. In terms of the outcomes, if you compare the outcomes with respect to cognitive and functional decline, and you look at the entire populations in both studies, very similar efficacy. So there's not necessarily a major gain with donanemab. One concern, however, has to do with some of the side effects, and this is the amyloid-related imaging abnormalities, which was found to be increased in donanemab compared to lecanemab. You see that it's almost double in terms of the ARIA-E or edema, and then higher with regards to the ARIA-H relative to the lecanemab treated patients in the trial. The infusion reactions, however, are cut down by about a third. So as opposed to being about a quarter of patients, this was seen in about 9% of patients receiving donanemab. You may be wondering when this drug will be available at the Memory and Brain Wellness Center. This is a work in progress. And in fact, today there's a pharmacy meeting to decide whether or not to put the drug on our formulary. And then we have some infrastructure building that will need to take place. And so this could be later on in 2024 or at the latest early 2025. Next slide. So I'll pass things on to my colleague, Darla Chapman.
Thank you so much, Dr. Rosenbloom and Dr. Grabowski, for giving like a really amazing overview of these products and talking about the mechanism. I will echo what Dr. Grabowski said, in that we are excited about finally having a disease-modifying therapy, and also add that we want to make sure that our patients who are eligible for this drug or who want to take this drug are offered it safely. And so I'm going to spend a little bit of time talking to you about the safety and side effects of these medications. Some of it has already been covered, but I think providing just a good summary of it will be helpful. Next slide, please, Kelly. So with these agents, we're talking mostly today about Leqembi and Kisunla, or Lecanemab and donanemab are their names. There are possible side effects, including what we could call either allergic or hypersensitivity type of reactions. So anytime anyone gets a new medication, we just don't know how one is going to respond. There are pretty, significant concerns about serious allergic reactions with any medication, but the hypersensitivity reactions that we look at for in these medications are things like fever, flu-like symptoms, nausea, vomiting, dizziness. And those are things that can usually be treated pretty well by our nursing staff in the infusion center. So those are not typically very serious, but there can be serious allergic reactions as with any other medication. Next slide, please. And then we did talk a little bit about ARIA, amyloid-related imaging abnormalities. This occurs in approximately 21% of people who get Leqembi and 36% of people in the donanemab studies. And these are total numbers. These are not broken down as Dr. Rosenbloom did with ARIA-E and ARIA-H. So these are the total percentages of ARIA cases on these two agents. Again, those changes are most commonly noticed on brain imaging as temporary swelling or bleeding in areas of the brain that usually resolve over time, and in most cases do not cause symptoms. People often don't know they've had those changes, and it's something that we see on brain imaging. And that's why we do frequent brain imaging at different points throughout the course of treatment to make sure that those things are not happening, and would alert you to that. I will say that a small number of people who have ARIA do have symptoms, and I'll talk about what those symptoms might look like in a minute. And again, as Dr. Rosenbloom mentioned, those amyloid-related imaging abnormalities are most likely to occur in the first 3 to 4 months of treatment, and the risk of having those changes increases if you have an ApoE4 genotype. Next slide, please. So these are some of the symptoms that one might experience with ARIA if ARIA occurs, although this can also vary from individual. And again, most people don't have these symptoms, but one would want to watch for things like headache, confusion, dizziness, changes in vision, difficulty walking. And we would want to know immediately from our patients who are receiving these drugs if any of these symptoms occurred. I will be forthcoming and say that in the prior study with Leqembi, there were 3 deaths reported of individuals taking this agent. Those also, though, were people who were taking anticoagulants or had other health conditions that put them at risk for bleeding. And so we have checks and balances in place to make sure that people don't have risk of bleeding, which includes some initial blood work and things that Dr. Rosenbloom spoke about earlier. Next slide, please. So again, this is a shared decision that that we ask our patients to make with their healthcare provider. It's a conversation. It's a review of the benefit and the risk. And before anyone is considered for this medication, your provider would go over your health conditions, any current medications that you take, making sure that one is not on any anticoagulants or blood thinners that could increase the risk of bleeding. There would be a brain MRI to look at the structure of the brain and make sure there's no existing microhemorrhages or concern. And then again, as mentioned earlier, some blood values to check blood clotting and ApoE genotype. Next slide. So once someone has been screened and is starting the medication, we monitor very closely for changes. Again, doing brain imaging prior to the first infusion, and then again before infusions 5, 7, 14, and 26. There also may be brain imaging needed outside of those dates as well. If new symptoms occur or if there's concern about ARIA, your healthcare provider might say, oh, we're going to do another one just to be sure. Okay, and then we will ask you about possible side effects at every visit. The nurses in our infusion center are trained in this medication and the side effects, and we'll ask several questions of our patients about any new medications or medical conditions prior to each infusion. Next slide, please. And we want to make sure that we stress this over and over again. This is a partnership. We want to work together with you. We want to have a good way of communicating with each other so that if things change in your health status, if there are new health conditions diagnosed or medications prescribed by other healthcare providers, that we know that, just to make sure that nothing is going to be contraindicated with these agents. And then we would also ask our patients to carry a medical alert card in the event there was a medical emergency outside of our system, or a way to tell other healthcare providers that you're receiving care from that you're taking this drug. Next slide, please. And this is the way to contact our clinic. Anybody who receives these medications will be given a contact card and know how to reach our clinic, and our nurse coordinator who helps with our Leqembi protocols and processes.